Ryan Stanton here with ASEP Frontline, and once again joined by our friend and repeat customer, Dr. Christina Shenvi. She's a fantastic educator, speaker. You heard her here with us actually twice back about 4 months ago. We talked about the early aspects of the topic we're going to have today, but also then we touched base with her at Scientific Assembly in Salt Lake City. And so some great content as well. So some motivation for you that if you've not heard those, to just go into the search engine of your favorite player and just type in Shenvi and Frontline. And I think there's probably 8 or 10 of them by now that we've had over the years. Always great content. And today we're going to build on one from 4 months ago about the management of anti-amyloid therapies in the ED and ARIA. We set the stage there 4 months ago with this, and we're going to today talk about the newly released point of care tool, as well as some of the other tools to make you aware of within the ASEP family of POC tools, and then as well as an update as what has evolved in the science and practice since we just talked 4 months ago. The management of anti-amyloid therapies in the ED ARIA tool was released and updated on December 10th, so relatively fresh, considering that we are actually recording this on the 11th, even though Ken has told me I'm not allowed to give date-specific type stuff. But yeah, it was just released, hot off the presses type stuff. So Dr. Shenvi, thanks again for joining us, and we'll kind of dive into where we are today with these tools.
Ryan, thrilled to be here. And like you said, there is so much evolution in this field. So we can update your listeners about the new point of care tool and then also give a little bit more about what's been going on with the field. So just to kind of get people up to speed, in case you didn't listen to our other podcast, there is a newish class in the last few years of medications to treat early cognitive impairment in Alzheimer's disease. And it's pretty amazing. The way it works is it's monoclonal antibodies that target the amyloid plaques that build up in Alzheimer's disease. And so the idea is you get these infusions of these monoclonal antibodies. They go across the blood-brain barrier, bind to those amyloid plaques, and then clear them from the body. And the two that are currently FDA approved are lecanemab, or Leqembi, and donanemab, or Kisunla. And it's interesting, Ryan, just since our last podcast, I've started on Instagram or Facebook or different platforms, I've started seeing direct-to-consumer marketing for these. I don't know if you've come across any ads yet, but they're out there at, sports games and other events and platforms.
Yeah, I've seen them. Now, some of that may have been our conversation and the targeted advertising that we get with talking about things, and the fact that my phone and computer are now listening. And if I wasn't getting a bunch of them before, I will be getting them a ton of them now, which is actually okay because I'm tired of seeing stuff about earplugs, which was my most recent little batch of things that I was getting. So let's dive in a little bit. Before we get the updates on ARIA and the anti-amyloid medications, the point of care tool, for those that are maybe under a rock, haven't listened to a bunch, or just don't realize there are a ton of point-of-care tools. This has been a very significant focus for ASEP to provide tools and to get the experts involved with putting together tools for diagnoses that we may see, some of them incredibly common. Let's just use AFib as one, and anticoagulation. And then others like this one, which may not be as common yet, but that are growing, in order to help us, to give us the tools to help us kind of work through a lot of this, these diagnosis and treatment quickly without having to each become our own expert, allowing to lean on the experts that put this together. So let's talk about the management of anti-amyloid therapies in the ED point of care tool.
Perfect. And like you said, this is literally hot off the press from yesterday. And to find the point of care tools, you can go to poctools.asep.org or navigate there from the practice tab at the top. And right now it's the very first one because it's the most recent. And the goal is, let's say you have a patient who comes in who's on these medications and they tell you, oh, I'm getting Leqembi infusions. or donanemab infusions. And you think to yourself, what is that? I have never heard of that drug before. What do I need to know about it? Then you could come, on shift, quickly use this point of care tool. So it'll walk you through the background of what are these therapies. Okay, they are for early stage cognitive impairment or cognitive decline in early stage dementia. And what do you need to know about them? Well, one of the key features are those amyloid-related imaging abnormalities that are usually asymptomatic, called ARIA, and they can show up on MRI. And typically, these patients are getting routine screening MRIs for them, but they can occur with edema or with little microhemorrhages. And if it's asymptomatic, why do we care? Well, if the patient is coming in with something that might require thrombolytics, like a stroke or maybe a STEMI, and you're out somewhere and can't get PCI, then if the patient has any evidence of that edema or microhemorrhages, then it's not recommended to give thrombolytics because they are at higher risk of bleeding. And then if the patient's coming in with something that might require anticoagulation, it's not a strict contraindication, but I would talk about the risks of potentially increased risk of hemorrhage if the patient is on those medications. So the point of care tool is great because it walks you through, okay, what do I need to ask the patient? What do I need to do for workup? If the patient is coming in with ACS or a massive PE, what are the considerations? Or if the patient's coming in with a DVT or a submassive PE, is it okay to start our normal oral anticoagulants?
And the beauty of this, the way it's written right now, is, of course, it's by emergency physicians for emergency physicians. And so with the headlines and the bullet points, it gets exactly to where we want to be with this type of thing. And it seems like a multidisciplinary aspect where most of us have these stroke-related teams that are going to involve neurology, neurology, stroke intervention, depending on your level of stroke care. And a lot of what it discusses here is that potential risk, the potentials that are there, and then the role of potentially MRI within that initial stroke evaluation, and then the shared decision-making with regard to thrombolytics with the associated risks and benefits. So this is something that, knowing that emergency physicians as well as the stroke teams need to be aware of potential therapies that are out there and what they can cause in terms of that increased risk. Because, of course, now we're seeing this huge push, especially with TNK, of expanded scope or expanded usage, even extended usage. And so with this push to increase the administration of TNK for acute ischemic strokes, obviously with the growth of these medications, and I'm not even going to try to say them just for the sake of, I think they just throw letters together for fun. It's the fact that, now the convergence is going to be with us in the emergency department where we may have that increased risk. So from your standpoint of somebody that is really into this aspect of the point of care tool, that pulling this into your practice. And by the way, you do not have to be an ACEP member to have access to these tools. So if you're a family doc out there, somebody who is a future ACEP member, because you qualify and you should join because that's important. I'm not just saying that as president-elect, but you should do it. It's the fact that these are available as a physician benefit to help emergency medicine and our patients. So not necessarily, you don't have to be a member for this. And so, as mentioned, poctools.acep.org. So talk about, implementing this and using this within your practice and helping make sure that your stroke or VTE care is as safe as possible.
Yeah, so this just helps put everything in one place, because even as somebody who's read a lot of the literature on this, it's hard to keep straight. So this puts everything in one place where I can look and say, okay, what do we know currently? Where is it okay to treat? Where do I need to really do shared decision making? And where is it a huge risk, like with TNK, if a patient has evidence of ARIA? The other place that I see using this is just for things that I don't want to keep in my memory. For example, to diagnose ARIA, there are some very specialized MRI sequences. And Ryan, MRI sequences do not make it on the top list of things I want to keep in my short-term memory. So I am not going to try to even remember those. But I know that if I need to look it up and say, okay, what kind of MRI do I need to diagnose this edema or microhemorrhages from ARIA, I can go look on it and it'll tell me, okay, I need a FLAIR, SWI, or T2GRE/DWI, all of those letters, so that I can put that in my comments to the radiologist or the text to know what I need to look for. So I think this will be something that I use as we have more patients coming in on these medications, which leads us to some interesting updates about the meds also.
Yeah, I'm going to, before you go to the meds, as ACEP is working more with AI potential, you're going to see a lot of this integrated within those. So your medicine-specific AI large language models and tools, a lot of these will be integrated into that just based on ACEP information and the relationships we're building with some of those AI out there. So, this is great access right now, the point-of-care tools, but, as we move forward, the expertise of our emergency physicians in their specific areas and talents will be able to be part of the larger picture of emergency medicine and healthcare-based information. But let's dive in. You mentioned updates that are going on with ARIA. So this is clearly an area of medicine that is moving rather quickly since we're 4 months into our last discussion, and yet we are very seeing already changes in evolution.
Yes. So to give a little backstory, a few years ago, kind of 2022-ish, 23, CMS approved Medicare coverage for the medications that are FDA approved. So that's lecanemab and donanemab. And the physicians or clinicians who give them have to participate in a registry so that they're keeping track of the patients and side effects, et cetera. And then more recently in 2023, CMS approved expansion of coverage for brain amyloid PET imaging. So I don't know about you, but when I was in training, diagnosis of Alzheimer's disease was purely a clinical diagnosis. Like, you've kind of ruled out it's not Parkinson's, it's not Huntington's, it's not frontotemporal. Therefore, we're going to just assume that this is Alzheimer's. But in fact, you can do things like brain amyloid PET imaging, and there are also some biomarker assays, and new things are coming out all the time to help with diagnosis, because these are somewhat risky medications potentially if you do have Alzheimer's disease. And it's also, they're quite expensive. They require, regular infusions every few weeks for like 18 months and monitoring with MRIs and things like that. So you want to make sure that you're treating the right patients. And then more recently, just a few months ago in August 2025, the FDA approved a sub-Q injector pen for maintenance with lecanemab. So after you get your 18-month treatment with your IV infusions, the idea is that if you have maintenance with a weekly self-injector or your caregiver injects it for you at home, then the hope is that that will help the amyloid clearance kind of persist.
You mentioned the initial injections and then the maintenance. Is there a time when the expectation or the patient is highest risk with these medications and the potential for being symptomatic, or the risk of the edema / hemorrhage that's associated with ARIA?
Yeah, so the highest risk is usually within the first 3 months. So if the patient has symptoms that are kind of nonspecific, like weakness, dizziness, sometimes focal neurologic deficits, or even seizures, especially in the first 3 months of starting the infusions, that can be symptomatic ARIA. But they can come in asymptomatic from the ARIA standpoint, but then have other things like a stroke that then you need to know about ARIA if you're considering using thrombolytics.
Well, interestingly, it's both sides. It's both sides of the sword. With the fact that the ARIA, though it's, and I'm taking this from the point of care tool, 10 to 30% of the patients are going to have some form of ARIA on the therapy. Most of those, of course, asymptomatic. 1 to 7% are going to be symptomatic, but can present with the neurologic symptoms for which, in many cases, we will be calling a stroke alert. Whether it's confusion, whether it's a gait disturbance, whether it's a deficit, those types of things, they can not only be cause the symptoms of a stroke that result in a stroke alert, or can complicate a traditional ischemic stroke type picture. So it's important to think about from both ways. So one of the first questions we have with patients when they come in is with EMS or the patients is, are you on anticoagulants? But now it's going to be if there is a concern or somebody coming from a memory care unit or something like that, is whether one of these medications is involved as well, because that may be the point of getting the stat stroke MRI with all your flares, SWIs, T2s, GREs, DWIs, whatever it may be, to knock those out.
Yeah, exactly.
Right,
it's kind of a catch-22 that, you need to know if it's ARIA causing those neurosymptoms or if it's a stroke, but then you still need to know if they have ARIA because of the risk of bleeding. And probably for these medications, it's approved more for the mild cognitive impairment. So it's less likely going to be our patients who are in, memory care units or severe late stage dementia, because at that point, I don't think, at least that's not what the population that these are studied in. But yes, and it would be great if there were a little flag in the electronic medical record that said this patient is receiving monoclonal antibody infusions for amyloid targeted treatment. But that is not yet in existence, at least in most places that I know of.
Well, no, it'd get in the way of all the sepsis alerts, all the sepsis warnings. This patient was breathing fast 4 weeks ago. They should be severe sepsis. Why have you not given 8 gallons of fluids? All right, you mentioned some kind of evolution changes research evidence from kind of around the world. Let's talk about where we are in terms of some of the stuff that's going on around the planet.
Yeah, well, I was curious, where else these medications are being used. And I also realized as I was reflecting, I think every podcast we've done together, I've had a make Ryan guess a random fact moment. So Ryan, here's your random fact. Guess. What percentage of the U.S. population is older adults? And then you have to guess for Japan.
What's your definition of older adults?
65 and over.
65 and older in the U.S., I would say is 25%.
Ooh, we're actually 17%.
Oh, yep. That's more. Okay. Well,
yeah.
Maybe that's my emergency department.
Japan, what do you think about Japan?
I think Japan would be older. I think Japan's older. So let's put them at 25%.
Yep, you're like right in the middle. So Japan currently is 30%, and the US is at 17%. And a lot of the European countries are kind of similar, like the UK is 19%, Spain, Sweden, 21%. Other countries like Saudi Arabia, I was just there a few months ago giving a talk about geriatrics, and I thought, I should know what percentage of their population is older adults. Only 3% right now. So there's a lot of variation, obviously, globally. But I was particularly interested in Japan because they have, one of the oldest populations currently. And they did approve donanemab in 2024 for use, whereas the European agency has declined approval for these medications at this point. Their version of the FDA is the European Medicines Agency, EMA, and they declined approval because of their concerns about ARIA-related events. The UK has kind of a middle ground where physicians can use it, but it's not approved for coverage by the NHS. So it's private pay. And it requires quite a lot of infrastructure for all the infusion, the monitoring, the imaging. And so they have made the decision not to use it, kind of weighing the risks and balances. And also, the NHS there's a lot of struggles across the pond and this side of the pond as well. And then more recent news, there are some newer medications in development. They're kind of being called the second generation monoclonal antibodies, with the goal of having them get across the blood-brain barrier better and clear amyloid more effectively, and hopefully with a better safety profile. So those are in the works, and I'm sure we will have a lot more news in this area in the coming years.
Now, the key to most of the questions you ask me is that I get them wrong. The only time I think the only one I got right is one where, I think the one at Essay, where you kind of gave the hint and figured it out as we were kind of saying it at the same time. And I still would not have gotten it.
It's become a tradition.
It is.
It's got to be a running trope. So every podcast we do, I've got to have a make Ryan guess a random fact.
And guess it wrong. That's the key. I mean, 25%. You know, I can guarantee.
We're not far off.
No, my emergency department, and actually that number's growing because of the aging baby boomers. If you look at the kind of the work ethic and lifestyles, and then with us in the United States, the baby boomers aging with a relatively shrinking pediatric population. I did pull it up right after you mentioned it, and it was at 16 and a half to like 17 and a half to 18 here in the United States, kind of consistently trending up. Now, that is a good thing because we do like for people to be healthier for longer, and we have more success, with elderly populations and functional wellness and health. But yeah, I'll be looking forward to the next one in terms of what we have. I'll have to get ChatGPT to get on it to get the topic and then say, what are the questions Dr. Shenvi is going to ask me that could be a fact related to this?
Oh, that's a good challenge because now I have to come up with things that are out of the box.
So tell us, kind of put a bow on everything here and make sure, because we talked about the point of care tools, some of the updates and some of the research and medications, kind of where this is going. Any kind of wrapping up thoughts on anti-amyloid therapies and ARIA in the emergency department?
Yeah, I would say mostly just being aware of it, being aware that it's out there, that there are some, novel complications with it that we need to be aware of. Overall, the hope is that this is, a net positive with patients having less cognitive impairment. And I think some of the real world long-term evidence is still, we're waiting for it. These drugs have only been around for a few years. So the real world evidence that'll come out, post-release with following these patients for longer to see how long is the reduction in amyloid or cognitive impairment sustained. What are the long-term outcomes for these patients? I think will be really interesting and important to follow. And, none of us are getting younger. So my hope is when we get through the second, third, fourth generation medications, by the time, Ryan, you and I need them, hopefully that we'll be in a better place. But in this moment, in our moment right now, just knowing to ask about them, or if you see on a patient's history that they're on it, pull up that point of care tool, refresh yourself, and hopefully the point of care tool will stay updated also. Refresh yourself on what are the recommendations. Currently, these are based on expert recommendations. Essentially, there are no, ACEP guidelines or stroke center guidelines or things like that for exactly who is a strict contraindication or not. But certainly patients who have active edema and hemorrhage, they are going to bleed potentially if you give them thrombolytics. So that's a pretty firm contraindication, although there's always room for shared decision-making if they're experiencing a devastating stroke. So, that's partly where I bump it up to my neurologist and say, hey, this is a complex case. I need to phone a friend. And most of the patients who are on these, they're going to be near major medical centers right now, at least, because it requires the infrastructure of regular MRIs, regular infusions. In the future, though, these might be a mail out subcutaneous pen like the maintenance ones are. So in the future, these could become far more widely available.
The challenge being there that, as mentioned in the tool itself, is that it may not show up under a medication list on the patient. If you happen to be at that facility, around that facility, or share information, it may pop up as a treatment plan or therapy plan flag on the EMR. But, it's not one that necessarily, since it's not a home-based medication for the most part, not one that's going to show up on the traditional medication list unless it is purposefully put in there, but, often it's not, just because it's pulled data from the pharmacies or prescriptions that have been written. So sometimes those experimental trials or therapy plans are going to be flagged elsewhere. The one question I did have before we break apart here is there any data evidence thus far related to ARIA, the anti-amyloid therapies with mechanical thrombectomy?
So the expert kind of consensus recommendations for that we came up with is if somebody does have a large clot, a large vessel occlusion with a stroke, and they're on these therapies, that doing a thrombectomy would be preferable to something like TNK. So that is the current state right now from our expert consensus was if you have thrombectomy capabilities and the patient is a candidate based on their stroke, then try to activate that pathway.
So an expert consensus rather than a plethora of existing high quality.
So we're working in
trials.
the realm of case reports right now, like case reports of bleeds from patients who received thrombolytics who are on these medications. So there's just not enough evidence yet, but we're doing the best we can with what we have.
Talking with Dr. Christina Shenvi, and once again, the point of care tools are available for everybody. POCtools.acep.org, and you can kind of roll your way down there. As I had it pulled up to get this one pulled up, I saw another one that I need to send to a local hospital as we're working on some bridge opportunities and medications for opioid use disorder. So a lot of great resources there. The one that's actually sitting right beside this one on the list right now is some smart phrases that you can use within your EMR. So check it out. And if you're not eligible to be an ACEP member, you're welcome. Enjoy the tools. If you are eligible, appreciate you joining us on this adventure together. And Dr. Shenvi, thanks for joining us again here on the podcast.
Thank you, Ryan. Always a pleasure.
And as for me, you can contact me at rstanton@acep.org, rstanton@acep.org. I encourage you to tag and follow the podcast on whatever player you like, so you're getting each weekly episode, not only of the Frontline, but also of So What, Dr. Howard Bell, and making sure that you give us a 5-star review to boost us up the list and get more listeners out there. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
There. Quiet place, all alone. Da, da, da.